Hi, my name is Dr. Maria Szabela. I specialize in HIV treatment. We are here in New York City for Ask Me Anything About CABENUVA. Come with me.
CABENUVA is for virologically suppressed adults and adolescents with HIV-1 who meet certain requirements. See full indication on screen. It is contraindicated in patients with a previous hypersensitivity reaction to cabotegravir or rilpivirine and in patients receiving the medications listed here. Please watch the entire video for additional important safety information. Please click the link to view the prescribing information for CABENUVA.
Welcome, everyone. Thank you for joining us. Let's get to our first question. What is the available data on CVFs for CABENUVA? With CVFs in CABENUVA, we have a breadth of data. In ATLAS and FLAIR, it was proven that once-monthly CABENUVA was as effective as a daily oral regimen. In ATLAS 2M, every 2-month CABENUVA was proven as effective as once-monthly CABENUVA. Then came SOLAR, which was the first and only head-to-head trial that compared switching to CABENUVA with continuing daily oral Biktarvy, which showed that every 2-month CABENUVA was non-inferior to Biktarvy. Across the clinical trials, the most common adverse reaction with CABENUVA was injection site reactions. Additional supporting data is provided by real-world studies, OPERA, and beyond. See study designs on screen, and for more detailed information, please visit CABENUVAHCP.com. In SOLAR, the most common drug-related adverse events in the CABENUVA arm were injection site reactions, or ISRs, consistent with the findings from previous studies. Furthermore, the discontinuation rate due to drug-related adverse events in the CABENUVA arm was 4%, of which 2% of CABENUVA participants discontinued treatment due to injection-related reasons. Notably, however, reported ISRs decreased over time, with the majority graded as mild to moderate in severity. Please see additional details on screen. In the pivotal studies and SOLAR trial, the rate of CVF ranged from 0.4% to just over 2% depending on the trial. Similar results were seen in the real-world studies beyond and OPERA. Overall, with approximately 2,000 patients in clinical trials having received CABENUVA, most CVFs occurred within the first 6 months of therapy. So now let's move on to question 2. Are there higher rates of CVFs with CABENUVA versus orals in the clinical trials and real-world studies? Actually, what we've seen is that the real-world studies supported the clinical trials, which showed that CABENUVA failure is very rare, and when it does happen, they can still resuppress. Keep in mind that participants entering the SOLAR study were stably suppressed on Biktarvy, a population in which we would expect the rate of virologic failure to be extremely low. These data are supported by the high effectiveness and similar low rate of CVF with CABENUVA and with oral ART in the OPERA study. Now on to our last question. Do CVFs always mean resistance? Across CABENUVA, clinical trials and real-world studies, resistance was rare and manageable. Low rates of virologic failure with resistance have been demonstrated in clinical trials and observed in real-world settings. Of the approximately 2,000 patients in clinical trials having received CABENUVA, less than 1% experienced treatment-emergent resistance. In the uncommon event of CVF with resistance, most patients in the clinical trials and in the real-world OPERA study resuppressed. In OPERA, the most common regimens participants switched to were oral integrase strand transfer inhibitor-based regimens. So I am happy to say I serve a community of over 1,000 long-term survivors as well as newly diagnosed individuals. And of those, over 100 patients are on CABENUVA. Now, as far as offering CABENUVA to these patients, I feel empowered by the clinical trials because in my own patient population, the rates of CVFs mimics all these trials that we've seen, as well as the real-world data. Thank you for joining me, and don't forget to check out other Ask Me Anything videos about CABENUVA.
Warnings and precautions. Hypersensitivity reactions. Serious or severe hypersensitivity reactions, including Stevens-Johnson syndrome, toxic epidermal necrolysis, and drug reaction with eosinophilia and systemic symptoms, or DRESS, have been reported with CABENUVA or its components. Some skin reactions were accompanied by symptoms such as fever. Other skin reactions were associated with organ dysfunctions. Oral lead-in may be administered prior to administration of CABENUVA to help identify patients who may be at risk for a hypersensitivity reaction. If a hypersensitivity reaction is suspected, CABENUVA should be discontinued immediately and the patient should be monitored. Post-injection reactions. In clinical trials, serious post-injection reactions, such as those shown here, were reported in less than 1% of subjects within minutes after the injection of rilpivirine. These events may have been a result of accidental IV administration and began to resolve within a few minutes after the injection. It is important to carefully follow the instructions for use and observe patients for approximately 10 minutes after the injection. If a post-injection reaction occurs, monitor and treat as clinically indicated. Hepatotoxicity. Hepatic adverse events have been reported in patients receiving cabotegravir or rilpivirine with or without pre-existing hepatic disease or identifiable risk factors. Patients with underlying liver disease prior to treatment may be at increased risk with CABENUVA. Hepatic monitoring is recommended and discontinue if hepatotoxicity is suspected. Depressive disorders. Depressive disorders have been reported with CABENUVA or the individual components. Promptly evaluate patients with depressive symptoms. Risk of adverse reactions or loss of virologic response due to drug interactions. Adverse reactions or loss of virologic response due to drug interactions with concomitant use of CABENUVA may occur. Use with caution in combination with drugs with a known risk of torsade de pointes. Long-acting properties and potential associated risks with CABENUVA. Residual cabotegravir and rilpivirine concentrations may remain in the systemic circulation for up to 12 months or longer. Non-adherence to injections could lead to loss of virologic response and development of resistance. It is important to initiate a fully suppressive regimen no later than 1 month after the final injection doses of CABENUVA when dosed once monthly, and no later than 2 months after the final injections of CABENUVA when dosed every 2 months. If virologic failure is suspected, switch the patient to an alternative regimen as soon as possible. Adverse reactions. The most common adverse drug reactions were injection site reactions, pyrexia, fatigue, headache, and those listed here. Drug interactions. For important drug interaction information, refer to the full prescribing information for CABENUVA, Vocabria for oral cabotegravir, and Adurant for oral rilpivirine. It is not recommended to co-administer CABENUVA with other antiretrovirals. Drugs that are strong inducers of UGT1A1 or UGT1A9 are expected to decrease the plasma concentrations of cabotegravir. Drugs that induce or inhibit CYP3A may affect the plasma concentrations of rilpivirine. Use in specific populations. Assess the potential risks of using CABENUVA during conception, pregnancy, and while breastfeeding. Please click the link to view the full prescribing information for CABENUVA.